I am really pleased to introduce Dr. Swick. She's the medical director of Ohana Center for Child and Adolescent Behavioral Health at Montage. She came and visited us at the Alliance a few months ago, and she was talking about some of the things she's done in the past, and I was really excited to get her talker into coming here and talk to us today.
Okay. Good morning. Dr. Dami, it sounds like you have such a lovely relationship with your child. I was getting ready for this talk last night, and my son asked what I was doing, and I told him about the talk, and he said, well, Mom, just be sure you don't talk too much, because you always talk too much. So it's a little less supportive, but duly warned. I'll depend on you to keep my eye on timekeeper. I'm wondering if you could quickly favor me with raising your hands. Who in this room primarily cares for adults? Works with adults. Okay. And who in the room primarily works with kids? Okay. And who works with people across the age spectrum? Okay. All right. Wonderful. So I'm delighted to have some time with all of you this morning to talk about child psychiatry and specifically about the role intervening with parents can have in preventing psychiatric problems in children. And I've come over the course of my career to feel that actually working with parents is kind of where the money is in trying to address problems with children. Now we only have 40 minutes, and you all know now that I talk a lot. So my hope is that you'll come away from this feeling like experts in child psychiatry. Oh, there we go. That was the first one. Such a riveting first slide. Okay. And as experts in child psychiatry, you really need to know that psychiatric illness is very common in childhood, right? Somewhere between 1 in 4 and 1 in 5 children will experience a psychiatric illness by the time they turn 18. That's twice as common as asthma, which affects about 11% of kids. And in fact, I want you to know that psychiatric illnesses are illnesses of youth, right? So fully 50% of all lifetime psychiatric illnesses will have presented by the age of 15, right? And 75% of all lifetime psychiatric illnesses will have presented by the age of 24. Right? 3/4 by the age of 24. And 24 is a magic number in some ways because we now know that's pretty much when the rapid development of the brain that happens in adolescence is wrapping up. That's when brains sort of become adult. And I would suggest that just as asthma emerges during early childhood, when children are busy fending off environmental pathogens, and they're frequently experiencing respiratory illnesses, right, as they're building their immune systems. Psychiatric illnesses emerge between the ages of about 7 and 24 as young people are managing growing challenges, expanding challenges with increasing independence, and they are building their psychological immunity, or what I like to think of as their resilience. Now, the good news is that these common illnesses are always treatable. And contrary to what you may think, they are usually curable, right? Approximately 75% of child psychiatric illnesses with the right diagnosis and proper treatment will be cured, right? One and done. And for the other 25% who will go on to manage a chronic illness, we have wonderful treatments so that the vast majority can go on to live healthy, happy, productive, satisfying lives. Now I know you all already know, and it's also important because this is what I'm going to be mostly talking about, that you know that psychiatric illness in children are often preventable. I've spoken with groups of child psychiatrists who sometimes don't know about this, so I love having the chance to talk about it with you. And all of you, though, can tell me about the bad news, which is how difficult it is to actually access treatment for child psychiatric problems, right? About 1 in 5 children with a psychiatric illness ever gets to see a mental health professional, right? 20%. And there's complex reasons why that is the case, but what matters to us here today is that mild illnesses become severe, development gets off track, and families suffer needlessly. And it also means that our pretty limited resources typically get consumed stabilizing kids in a crisis, right? Preventable crises. And if we can invest even a fraction of our resources in prevention, we can make a much bigger dent in the overall problem. Okay. All right, my burgeoning experts, let's see if I'm good at this. Okay, we'll see if this works. Let's turn to anxiety. We're going to talk a little bit about anxiety because as experts, I want you to know that anxiety disorders are the most common psychiatric illnesses in youth, far and away. 30% of all the psychiatric illnesses that young people experience are anxiety disorders. So this graph is from the NIMH, and the anxiety disorders are represented here in the red line. And you can see that they start the earliest. So the y-axis is the cumulative percent. So this is the cumulative prevalence of these illnesses from the age of 4 on our x-axis all the way out to 18. Anxiety disorders start the earliest along with behavioral disorders, which are the blue line, right? And they have large increases in incidence each year, and then they drop off somewhere here around 14 or 15. The second most common illnesses are behavioral disorders in the blue line. That's ADD and ODD and other externalizing, very observable disorders. These are disruptive kids. And again, this starts really early. There's some incidence around 5 or 6, and then it pretty quickly drops off. The third most common disorders are mood disorders. This is kind of contrary to what people think. People typically think that the most common illnesses of youth are depression in teenagers. But actually, it's not even close. Their third place, they certainly do have a jump in incidence in adolescence, right around the time that, that anxiety and behavioral disorders are dropping off in annual incidence. Mood disorders start to increase. But mood disorders are quickly overtaken by our purple line, which is substance use disorders, right? Which start around the same time and then overtake them around 17 and jump up into second place. Mood disorders only really increase in incidence above anxiety disorders later in adulthood, when we know only a quarter of psychiatric illnesses emerge. Now, anxiety disorders are among the most curable, right, of all psychiatric illnesses, and certainly this is true in children. First-line treatments are usually psychotherapies. There's a lot of evidence-based psychotherapies that are very effective, and they can be augmented with medication treatment if necessary. Anxiety disorders can be difficult to diagnose, though, right, because anxiety is often what we call an internalizing symptom, right? So it can be a hidden, quiet, internal symptom. And of course, anxiety is a normal part of life. It is very much a normal part of development. I'm happy to talk more about that, but most 5 to 8-year-olds look like they have an anxiety disorder because they just do it as the age of anxiety because their cognitive skills have really skyrocketed. All of a sudden they understand logic, they understand cause and effect, but they don't have a lot of life experience to be able to put things in perspective. So when an 8-year-old learns about global warming, they become overwhelmed with the seriousness of this. They're like, the world is burning up. It's predicted that by like 2079, the temperature, like my 10-year-old son talks to me about this, the temperature is going to be incredibly hot. We won't be able to live except maybe in northern Canada. How come we're not marching? And I'm like, yeah, well, we have to cook dinner. You know, they don't have, they don't have the lived experience and the emotional tolerance to be able to bear scary things. We should listen to them. I agree. I agree. I'm not saying denial is necessarily long-term adaptive, but it gets dinner on the table. But it is very much the age of anxiety, right? Where their cognitive skills really outpace their emotional experience and maturity. So they have a hard time figuring out, and as do all of us maybe, how to strike a balance between things that are troubling or problematic, whether it has to do with imminent threat or with bigger issues of like social justice, and being able to sort of figure out how am I going to weave this into a life that still has some balance in it? How am I still going to get sleep and eat dinner? So they don't have that experience yet, so they tend to get really worried about things. So tough to diagnose. See, I talk a lot. It's tough to diagnose anxiety disorders, but we have great screening tools. So most kids, whenever they fill out a screening tool, will actually admit to anxiety symptoms that often their parents don't even know about. So just with proper screening, they're much easier to diagnose. And if they're not treated, anxiety disorders actually lead to considerable morbidity. They don't often lead to mortality. Anxious kids tend to avoid risk. And it doesn't often get associated with suicidality, unlike mood and thought disorders. But they lead to tremendous morbidity. So untreated anxiety can lead to really impaired school performance, great withdrawal, not taking chances with things academically. It leads to very impaired social development, which is a big deal for kids, right? They really get off track developmentally. And it can lead to other psychiatric comorbidities and complications like depression and substance use disorders. Anxiety disorders are also among the most heritable psychiatric illnesses. So a child who has a parent with an anxiety disorder is 3 times as likely as their friend without a parent with an anxiety disorder to develop an anxiety disorder themselves. Now, here we have a population, right, who has a known high risk for a curable illness that can have terrible complications if it doesn't get treated. It makes these kids wonderful candidates for prevention strategies. And I'm going to tell you about a program. There's a group of adult psychiatrists in Connecticut working at an anxiety disorder clinic that were aware of these facts. And they had a cohort of patients, large population of patients who had children. And they decided to build an intervention to see if they could prevent the emergence of anxiety disorders in the children of their patients, right? So they invited their patients, these are adult patients with treated anxiety disorders, to participate in a study in which they would give them an 8-week intervention. It was a curriculum. It was essentially a psychoeducational and skill-building curriculum for these parents that is at its end essentially aimed to help them manage their children's stress, anxiety, and worry in ways that were calm and constructive. So instead of escalating or catastrophizing along with their child, and these are things that are challenging for all parents, right? But they just built skills at remaining calm and having constructive responses with a child's stress or anxiety. So to participate in this study, all of the parents, their children could not have a diagnosed psychiatric illness. They put half the parents into the control group, into a control group that got an 8-week parenting support program, and half the patients into the active intervention group. And then they followed the children. And what they found is at the 1-year mark, the children of the parents in the control group, 30% of those children had developed an anxiety disorder. And that's a high number, and that's actually about the rate you would expect in that high-risk population. In the active intervention group, the children whose parents got this educational program, only 5% had developed an anxiety disorder at the 1-year mark. Now that's a wow number, and in fact it's more wow than you think, because that rate is lower than the expected rate in the general population of an emerging anxiety disorder at that age, right? So that's vaccine level power, right? And just like vaccines, it is cheap, and it didn't have to be administered by a physician, right? This is powerful intervention. I want you to know that there are similar interventions that have been developed for other heritable psychiatric illnesses, like depression, eating disorders. Did you know that that was heritable? They're very heritable illnesses. You knew. I know you knew. You're good. No, that's great. Even ADHD. And the central theme of all of these interventions is to treat the parent's own illness, and then you fortify their ability to help their children develop healthy self-regulatory skills, right? Okay, so prevention works. And now we are going to turn to something else, because beyond a family history of psychiatric illness, there is another well-established risk factor for psychiatric illness in children that is ripe for prevention strategies, right? And this is adverse childhood experiences. Now, I know that everyone in this audience is already expert on ACEs, but I like to include this slide to remind myself that while some of these experiences, like physical, sexual, and emotional abuse, witnessing the physical abuse of a parent, some of these are traumatic experiences, unequivocally traumatic experiences. Others are milder stressors, right? Experiencing an illness in a parent, divorce, a relative who is incarcerated. But what's important to remember is that almost each of them involve an intense or sustained stress alongside impairment or absence of a parent, impairment of a parent's ability to help that child manage that stress. All right, you already know that such experiences are very common, right? 2/3 of adults have experienced at least one ACE, right? And nearly 1 in 6 adults have experienced 4 or more. 1 in 6. And it's not just who you think. We know that the overwhelming adversity in childhood creates a very high risk for problems in adulthood, right? So adults with an ACE score of 4 or more, and 4 seems to be the magic cutoff number, although of course with every additional ACE score your risk goes up, right? But 4 seems to be the magic cutoff. Those with a score of 4 or more are twice as likely to be obese in adulthood, twice as likely to smoke, 7 times as likely to abuse alcohol. They are 4 times as likely to have emphysema or chronic obstructive pulmonary disease, 5 times as likely, and this is all for those with less than 4. It can be, this is including the control population of people who have scores of 2, right? They are 5 times as likely to have depression, 12 times as likely in adulthood to attempt suicide, right? They have higher rates of heart disease, autoimmune diseases, and cancer. Those who have a score of 6 or more have a life expectancy that is 20 years shorter than those with lower scores. All right. And we know that adults with high ACE scores are much more likely to have children who are currently experiencing high levels of adversity, right? So those parents with a score of 4 or more have children who are 6 times likelier than their peers who don't have parents with high ACE scores to have a parent who abuses substances. Their kids are 10 times likelier to experience homelessness. They are 12 times likelier to experience neglect, 13 times likelier to witness violence in their community. They are 44 times likelier to witness the physical abuse of a parent, right? These kids are at very high risk in the short term for behavioral problems at school, for sleep disorders, for disruptive behavior, and then later for early experimentation with substances, which increases their risk of addiction, and then risk for depression, anxiety, and high risk of suicide. A continuation of this cycle of adversity, right? But do not despair. Remember, if experience can negatively affect the developing brain and body so profoundly as I just told you, experience can also heal, right, or protect. You know, I just told you about a lovely study that showed that we can provide children with experiences that improve their resilience, right, that vaccinate them, that inoculate them, and protect them against illness. And when we equip their parents to provide those experiences, they're jet-powered, they're super-powered. Because parents are with their children all the time, and parents are doing critical modeling for their children, right? That kind of intervention improves the health and well-being of an entire family. So I want to tell you about one more really promising intervention. Now, Family Foundations is an 8-session prevention program that was developed by Mark Feinberg, a psychologist at Penn. And he developed this looking to try to find interventions that might prevent peripartum depression. And they are educational and skill-building interventions, 4 sessions before birth and 4 sessions after birth. And it's entirely a horizontal intervention, meaning it is an intervention offered to a couple, right? So it's to 2 parents or to a mother and the other primary adult caregiver who will be helping her with her child. And it is all based on improving communication skills, problem solving, and stress management as a couple, right? And this intervention's been very well studied. And they found that it did lower peripartum depression. It improved parental attunement to one another, lowered parental conflict. But they also found that they had more full-term births. They had better birth weights. Better birth weights. That's incredible. They found that there was much better attunement of mother to baby. And then these protective effects were sustained. These children did much better than their peers, and they have done case control studies of this protocol. These kids did better than their peers with their self-regulatory skills, with their social skills, and with their academic performance. They followed these kids up through the age of 7, and they're still studying them, right? This intervention was so promising that the Department of Defense decided to purchase it, and they provide it for all enlisted personnel, where one member of a couple gets pregnant, because the DoD knows that enlisted personnel actually are at much higher risk to have high ACE scores, right? Enlisted personnel are twice as likely as unenlisted adults to have an ACE score of 4 or more. Many people join the Army to escape adversity, right? So we'll keep you posted about what this promising intervention looks like when their kids hit adolescence, but there's no reason to think right now that it's not got profound long-term protective effects. Again, think of this. This is an intervention that required bachelor's level people to provide it. You did not need doctoral level people to do this couples intervention. So I hope that you leave this meeting thinking about the great opportunities to prevent disease in young people and their families, right? And thinking about risk in children, it's typically either internal or genetic or external, right? Something in the environment or an experience the child has that confers risk. And usually it's both, right? A genetic vulnerability and some environmental or experiential exposure that triggers expression of that gene. But if we think about parents, and parents teach us something both about a child's genetic picture and their environment, right? And if we can intervene with parents to prevent illness and promote resilience in their child, we dramatically enhance outcomes for that child, and I would suggest for the whole family, for the parents as well. Now, of course, the problem of actually accessing effective interventions remains, right? Even though they are relatively inexpensive and can be delivered by bachelor's level folks, good luck, unless you're in the Army, it's hard to necessarily access these evidence-based therapies. And I want you to think about what each of us could do when we leave here today for these families. So I invite you to start by thinking about the nature of ACEs, right? Think about these risk factors and the things that we do in each of our capacities to help protect families from experiencing these things, and parents from experiencing these things that they can, in a way that they cannot protect their children or cushion their child's experience of it, right? So really, to support healthy parenting, some of our work probably needs to be advocacy, right? And I include those of us that are physicians, like bachelor's to doctoral level and everything in between. Advocacy about ensuring parents have access to a living wage, right? To affordable housing, to good health care, to mental health care, to high quality child care. I'm probably preaching to the choir, but I really like to say advocacy should really be an explicit part of what we always do. But beyond advocacy, when you are working with a parent, or a patient or a client who is or who might become a parent, you can be a tremendous resource for them and for their families by educating them about their risk, reminding them of their resources, and then helping to promote their resilience. Okay, so you educate, you remind, and then you promote. So educating them about their risk, you need to first assess a parent's level of risk. What is their ACE score, right? Do they have risky behaviors such as substance use that may bring adversity to their children's experience? Do they have a mental illness? Do they have a medical illness that needs care? Are they experiencing domestic violence? Does their child carry extra risk because of a family history of psychiatric illness? We don't just ask these questions so we can check boxes in our electronic medical records, right? What we do is we ask these questions and then we talk with our patients or clients about their level of risk, right? Talk about what it might mean for them, for their health and well-being, and for their child's health and well-being. Knowledge of risk to themselves and to their child is power. Knowledge is power, especially when you frame it with hope, right? When you remind a parent that this isn't just bad news. Talking about risk can feel pretty depressing, but hope starts with also considering their strengths, right? And I like to think about what are their resources? What are their internal resources and their external resources? And their internal resources are generally skills, right, and abilities. Do they know themselves very well? Are they intelligent? Are they tenacious? Are they flexible? Are they patient? Are they humorous? Tell them. If you have noticed these things about them, you can think of at least one thing of anyone you work with that is a strength, right? That is an internal skill or talent that they bring to challenges. Tell them about that. Affirm it. Be like, I love your sense of humor, or you have extraordinary patience, or I appreciate your flexibility. This isn't just throwing sunshine at them. It's fortifying for people to be reminded of their inner resources, of what they are capable of managing. It's very powerful, especially when it comes from someone in a helping profession, right? When patients or clients come to us, they often are feeling powerless, right? And like they need to depend on, like they need to depend on clickers, like they need to depend on others for help. Remind them of what they bring, what wonderful talents, skills, experiences they bring. Then think about what are their external resources. People often start with money. Money can buy you a lot, but money is actually not the critical external resource. You really want to pay attention to their networks, right? Their social resources. Do they have even one loving, supportive relationship with a family member? Even one loving, committed, supportive relationship with a friend, with someone they're not related to? Do they have a supportive faith community? Do they have a satisfying job, right? Emphasize these resources. Remind them of their list of resources and remind them to utilize these supports. This is how you help start the process of promoting resilience. And this is for them, and it promotes resilient parenting. Now, I could talk for hours and hours, according to my son, about resilient parenting. But I will say, I know, look at this photo. Doesn't it look so easy and nice? That's what dinner looks like in my house every night. We're so happy. We're eating eggs. Resilient parenting is, at its most simplified, essentially about striking a balance between being attuned and responsive to your children and still being able to set rules and enforce them, right? Resilient parenting is sort of about being both bad cop or good cop and bad cop at the same time. It sounds simple, but it is not easy. It is not easy. Doing this consistently requires that parents are managing themselves well enough to be able to help their children face difficulties, face external difficulties or internal difficulties, and gradually develop those building blocks so that children can eventually manage themselves by the time they reach 24, right? Real adulthood. Now, to do this, parents need to be present, and that's why I start with show up, right? And I also, showing up alone, you're halfway there to resilient parenting if you are there with your children in predictable, consistent ways. This does not mean that you are eating eggs together and smiling every night, right? But that there is some consistency and predictability to time together, right? So if parents work or they work several jobs, if they still have predictable availability and times to connect with their children. Maybe they have dinner together once a week and they drive to an after-school program or to a job or to a practice. Maybe they get together to watch destination television. That counts. Predictable, consistent time with their kids is essential, right? They should be doing this enough that they can describe basically what a child's working on in school and name 3 of their friends. If they can do that, they're showing up enough. And that matters to me because I have 4 kids and I don't always know my kids' friends or what they're working on in school. Then you want to know, can they describe their child's special gifts, their special talents? What sets them apart? And they have to be present in order to establish routines. So that bad cop part really isn't just bad cop. It's about setting and creating routines you expect your children to participate in, setting expectations that your children will work to live up to, and explaining very clear rules and then enforcing them calmly and consistently. Again, simple but not so easy. If you only help your parents think about self-care and then teaching and enforcing self-care for their kids, you are doing a tremendous amount to promote resilience of that individual parent and then in that family system. So I talk about self-care as being common sense, right? So sleep, exercise, nutrition, I fudge that S. It's like screen time or social connections, and engagement. Right? So can parents practice and teach a consistent bedtime routine that protects a restful and adequate night's sleep? This requires great discipline. Getting everyone to get the screens out of the bedroom and go to bed at a reasonable time is very hard. Do they prepare or do they model good care of their bodies with regular, reasonable exercise? They don't have to be triathletes, but they go for walks when they can. They take the stairs when they can. Do they prepare and enjoy healthy food? Do they use it for nourishment of their body as well as social connections, but not for escape or self-soothing? And do they have nourishing, caring social connections that they nurture with time and energy? And do they invest in activities and these social relationships and work that is engaging and meaningful to them? Or are they spending much of their time escaping into screens or worse, into substances? Most importantly, and we're almost done, remind parents you work with that failure is the rule, right? Failure is the rule. Each failure is an opportunity. Now, if their child fails, that's gold. That's money in the bank. Those are the wonderful chances to practice managing a challenge, right? Just like learning to ride a bike, it is only by falling off over and over and over again that children actually find their balance, right? That is how they learn. If they aren't failing or falling, they actually aren't exploring enough, right? And when a parent fails, I don't say if a parent fails, we all fail. We fail every day. We fail probably dozens of times a day. But when they fail, if they can catch themselves and do a repair, say let's imagine a small failure, like a parent loses their temper and yells, does not model calm, consistent enforcement of the rules, right? That's a wonderful opportunity to be able to say they're sorry, to explain what was going on, that they felt stressed out, and that they lost it. This is modeling for our children, right? That each of us gets stressed and periodically overwhelmed, and that it's possible to reestablish calm, right? To apologize and to move on. I point this out because I really don't want you to come out of this feeling like a parent's job is to protect their children from all adversity. That is not the case. And in fact, parents who strive to protect their children from all adversity end up with a whole other set of very serious, difficult problems on their hands, right? On the contrary, children are supposed to be facing adversity. That is how they build their psychological immune system, right? That's how they're going to grow into healthy, independent adults. It's how they build resilience. But parents need to be able to sit beside them or run behind them, right, while their children are facing and managing all of this adversity to support their ability to fail, pick up, and start again. That's how they really build their own skills and independence and resilience. When a parent is impaired and unable to do it, or if the parent is the source of adversity, that's when we have trouble. Those are ACEs, and that's when we need other caring adults in the orbit of that family to try and offer repair, right, and support. The last thing is when challenges a child's facing bring strong emotions, this is something else you can offer the clients or patients you're working with. It can be really, really helpful for parents to practice essentially mindfulness, with their children. Not too many parents and kids are going to be like out there meditating together. Maybe some of them are. Maybe in Santa Cruz it's happening. But essentially, when they get to try and reestablish calm and practice non-judgmental acceptance of something difficult or uncomfortable, and they practice it together, that's fantastic. That's great resilience-promoting activity, right? And it doesn't have to be meditation. Often it requires sort of a physical substrate, especially for families that have experienced trauma. Trying to meditate after trauma often is a recipe for disaster. So finding physical activity that actually starts to sort of set the body into a rhythm. Maybe it's shooting hoops. Maybe it's going for a walk. Maybe it's baking bread or cookies. We don't want to escape too much, but cookies are good. Help your clients or patients find an activity that they enjoy, that has a sort of rhythmicity to it, and that they might enjoy doing with their child. There's lovely studies, if I had time I would tell you about parent and child learning to play violin together. And the exquisite way, and these were for very, very stressed, traumatized families, and the exquisite way, and they did amazing actual neurological scans of these kids before and after, and it was a 2-year intervention, so it's long term. But here's the great thing about long-term interventions. Parenting is long term. Help them find an activity that's rhythmic, that it includes non-judgmental acceptance of failure. Shooting hoops is mostly failure, at least for me, right? Learning violin, mostly failure, right? And that is money. Okay, and last, communities can promote resilience too. It is very powerful when parents know where to turn, even if we can't decisively address the problem. Just sitting beside or running behind a family as they are facing a challenge is very powerful, right? And their children learn how to ask for help, that it is good to ask for help. It takes great strength to know you can ask for help. And they learn that there is a broader community outside of their home that cares for and about them. So again, I appreciate having the chance to join you. I'm very happy to have joined this community somewhat recently, and to try and create another thread to add to the fabric of support that all of you work so hard to build around the families here, to help support families and support them in raising happy, healthy, and resilient children. So thank you for your attention and your time.